Just in case for those who don't know, we are the Health Innovation Network, and we are one of 15. We were established in 2013, and our main role is to sit between the NHS and industry, providing support to find, test, and implement new innovative solutions. And we do that right away through our something called the innovation pathway. So depending on where the innovator is on their journey, we offer support right the way through from ideas development to spread and adoption. So just to give you some quick background and context to where this all came from, you probably know the government landed its Get Britain working plan to address unemployment and economic inactivity. And our ICB received 18 million to improve population health and reduce health in related economic activity. And we've been working very closely with the ICB since January, supporting them on the digital innovation arm of that, which involves supporting the innovators around contracting, performance monitoring, adoption and implementation plans, and also evaluation. So as part of it, we did way back in January, February, we did some horizon scanning, market research work to identify suitable digital innovations across the themed areas, which helped us to then design a national innovation call that went out to industry, asking for relevant solutions across these themed areas. We got a huge response, and those applications went through a thorough screening process and shortlisting process. And we had various multidisciplinary panels set up consisting of experts across the system and clinicians, and of which Richard Duggan was one of them. So thank you very much for your support. And I'm delighted to say one of the successful ones was Dr. Julian, who's now I'll hand over and is going to go through the platform.
Thanks a lot, Christine. It's lovely to meet you all, and look forward to working with you. So I thought I'd just give you a little bit of background about us, and then sometimes bringing the platform to life through a demo is the best way to sort of go through it. So how did it all start? So I'm a GP by background. I still work a day a week, and actually at the time I got inspiration from working in A&E. Unfortunately kept seeing patients who were trying to end their lives. And when asking them, they were always saying, I'm on a 9-month waiting list to get help, or I'm on a longer waiting list, etc. And I thought, the real way to get someone support is by providing good quality therapy. And I thought, okay, why can't we get people better access? Why are we not getting people immediate access? Why are we waiting this amount of time? And why is it that someone gets the next available person potentially without any matching, etc.? And also, I thought the technology that we're using in healthcare is very outdated, and crucially doesn't have a patient-facing side. And I was like, well, why don't we have a patient side? Because then you can empower people, you can give them access to what they want to do and actually personalize the care. So that's where the sort of original inspiration came from. And this started out now 9 years ago, where we said, okay, let's try and build a platform whilst providing therapy services. So we started out, and over 9 years, we've sort of been developing this technology in collaboration with our clinicians that we have and the patients, constantly iterating it off feedback. And we've got this constant pipeline of development that we do with the platform to try and make it as good as possible. And we built it on modern code and in a modular fashion, so you can use bits of it. Organizations can use whatever bits of it that they want and turn off other bits, which means that it's actually really easy to sort of innovate on and build out new features and stuff. So we always work with our clients based on what they would like as well. So if there's any feedback from you guys of actually this would be really helpful to have this extra thing on our tech, then we'd love you to sort of feed that back to us, because that's sort of what we're doing all the time with it. We are now a national provider of mental health therapy services across the country. We work alongside other services to support them with their waiting lists. We have a network of clinicians of around 350 or so clinicians covering the full spectrum of mental health. I think with yourselves, we're mainly covering step 3 with CBT, I think EMDR for trauma, and we do other counselling services and specialist counselling, but we've sort of got a broad range of services that we offer, including more specialist ones like eating disorders, maternity services, and we run things like the National Ops Courage Service for veterans. And the key point for me is getting patients that instant access to help with no waiting list, and getting the right clinician for you. So, do you need someone at whatever time that you need them? So we operate between 7 a.m. to 11 p.m. at night, 7 days a week, 365 days of the year. And patients, crucially, are empowered to find the right clinician for them. So they get access to the network, and they can communicate with that clinician. And we really try and match you to the right person, including whether that be language preferences, etc., culture preferences. So someone, we found that we can really improve engagement by people finding someone that's most suited for them. That's kind of the idea behind it as such. Really trying to put the patient at the heart of things is where that stemmed from. And it's, we're continuing to grow and getting people sort of that real instant access. To bring it to life a bit, I was going to, I'll go through the platform for you. Can you see my screen? Yes. Hopefully, yeah, perfect. Okay. Yeah. So from a patient flow and journey perspective, I think you guys are using iAptus, aren't you? So what happens is we're integrated with iAptus, and all you have to do is click refer to Dr. Julian on the patient that you have in iAptus, and that will automatically send the patient to us. And I'll show you the back end in a minute, but you can also access the back end of the system to see the patient in our system. But I was going to talk you through the sort of journey of that patient. So the patient that's eligible for us, I think you're referring step 3 at this point. Again, you can refer different steps if you want to, but I think we've got a step 3 portal where you'd refer into that. The patient will then get an email once being referred in of how to log into the platform and register themselves and create their password. We have iPhone and Android apps as well as this web app. So I'm showing you the web app, but the same functionality is if they log into the iPhone or Android app. They then get this home screen, and we have a resource library. So we have a large resource library of mental health resources that we've collated and gathered of the best ones that are used in talking therapy services and in mental health services. They might be videos, guides, worksheets, etc. that we've collated. And they also can link out sort of to other resources. You might have your own resources that you guys use, and we can actually add those in as well. We have a resource library builder, which I can show you. And so if you've got specific resources that you'd like our patients to be looking at, then we can also put those into the platform. The patient will get the sort of resource library that we've allocated that they want to look at. They can favorite resources, and our clinicians can assign resources to patients so that they would be able to see them. So that's the sort of self-help element of it, and to help people before, during, and after their sessions. We've then got the booking system. So a patient will be able to find an appointment that most suits them through our clinicians. So they can filter by date on here and to find the right, the timings of the day. And then we've got different filters up here as well. So if someone knows that they have a particular specialism or issue with anxiety or whatever, then they can click that. They can also find someone of the right language that they speak if they want to find someone that speaks that language. If they're struggling with the system at all, we have a very extensive customer success team that's run by Amy on the end of the phone and also on an email. So if a patient can't access the platform themselves or has a digital illiteracy problem, then our customer success team can do that on their behalf as well. And likewise, we can talk them through sort of how this works. But we do find the vast majority of patients, I think it's around 95%, actually really like the fact that they can go through and book it themselves. And we've got very good feedback and Trustpilot reviews on that. So they will find a clinician and they'll be able to read the biography of that clinician. So they like the fact that they can sort of see who is that person that I want to book with. They can actually speak to them beforehand and contact that person as well. And then they'll go through and see the calendar of availability of that person. Now, again, if someone's not available at the time, then our customer success team will help liaise with that client to coordinate how best to fit that person in. So normally pretty accommodating on that. And then they can go through and click the book appointment slot that they would like. And we offer video, voice, instant message, I think, appointments. I don't know if we ourselves, we're just doing video and audio, but we can also do instant message. And then that appointment gets booked, choosing the medium. The therapist is then notified of that appointment and then contacts the patient. We have a whole range or array of emails that get sent out at different triggers to remind people to book if they haven't booked, to remind them to do their assessments if they haven't done them, etc. So there's a whole array of emails and reminders, etc. that go out. We also have a text messaging system that will text them, and we have an in-platform communication system under messages here, so we can communicate with patients through the platform as well securely in that sense. When the patient has the appointment, they will then be assigned various assessments by that clinician. Obviously, I'm sure you're all familiar with the GAD-7 and PHQ-9, but essentially they get to do it on the platform, again, because of this patient side, before the session. If they haven't been able to do it before the session, the clinician can do it with them in the session, but we find, again, through our reminders and stuff, patients can fill that in. And then we're doing the IMT scoring as well, from assessing if people go back to work, and really sort of making sure that we collect the outcome data for that. It will give them the results. They can also go back and look at the previous assessments and how they've are they recovering, etc. on that as well. So they've got the assessment, and then everything is in one place, because at the time of the appointment, it obviously reminds you of the appointment, but they have mainly booked it, unless obviously our customer service team has. But because patients have booked it, they actually turn up for the appointment. So our did not attend rates are sort of less than 2% normally. And then they just have to log into the portal or to the web app, and then we have secure inbuilt video conferencing technology inside the platform itself. So there's no needing to send a Teams link or a Zoom link or etc. So that's all done in one place. And then after the appointment, the clinician will write the notes, which I will show you in a minute. One other thing is that the patient can access their notes and letters through here. So under the profile, they can look at the discharge reports. And they can download them, for instance, so that we don't have to necessarily send them in the post, but we also go and communicate with their GP, so they'll be able to see that.
Julian, sorry to interrupt. I was just wondering, is there any way you can make that any larger or not on the screen?
Sorry, which one? This one?
Just the whole thing. Yeah, that's better. Yeah, marvelous. Thank you.
Okay. Can everyone? Sorry, everyone see that? That's fine. Just showing that we can brand everything as well based on branding. So depending on what, this is one of our clients is Gloucester for their talking therapy service. So again, you can sort of brand the letters, etc. that go out. So yeah, booking system, patients can book themselves mainly. Resource library that gets personalized to them, and obviously localized to the area that person's in. Assessments. The other thing is they can also change their appointment through here if necessary. So again, much better to really collaborate with that patient through that patient side and the messaging center. That kind of covers the patient side of things. Is there any questions on that before I move into the back end? And I can't see anyone, so someone else will have to tell me.
There's nothing in the chat, John, and there's nothing in the question section.
Richard,
yes, Richard, do you want to come in?
Yeah. Thanks, Julian. That's brilliant. If people wanted to choose their therapist around their preferences, I can see how the language would work. But say, I don't know, what other preferences can they kind of search for? So I was thinking, say somebody might want an LGBTQ+ therapist or something like that.
Yeah.
How does it work? You don't have to read every biography, presumably.
No. So do you see these filters here?
Yeah.
At the top. So you just filter by issue. So under there, you've got different issues, including the LGBT. So if there's a clinician of that specialty, then or of that special interest, then they'll be able to find that clinician under the issues by selecting through the filters.
Issues. Okay. Yeah. Thanks so much.
Likewise, if anyone's struggling, then they just contact our customer service team, and we will, be able to accommodate. The advantage of having the clinician network that we have, and we actually have a whole range of clinicians waiting to work with us as well, that we know their specialism, is that we really can give personalized care, because you've got a much wider pool. And that, again, was sort of my original idea, was if you use a national workforce of clinicians, then you can find someone that's much more suited for that individual, rather than I've got a network of 5 clinicians. So that was the idea behind that. And it makes life easier for the clinician, because they can upload availability when it suits them as well. So sort of making that connection a lot more seamless. Okay, my internet here isn't great because I'm actually at a conference as well, but I managed to find a quiet space, so I'm sorry. I've been presenting at the BMJ conference. Right, can you see this bit? So this is our back-end system. So the system itself, over the 9 years that we've been building it, now kind of does a lot of things. And it kind of works as a fully fledged electronic record system, case management system, and lots of other things that it does, including that patient-facing side. Other organizations are using it to run and operate their entire services on as well. From this perspective, I'm going to be showing you how you can access the system in your backend. So what we do is we create what's called tenancies for the different services that we operate. So obviously, I think we're doing a step 3 pathway for yourselves, and I don't know if we're setting up a separate tenancy for each work wellbeing hub, because we can do that so that each area can have completely customized tenancies for that. And what will happen is, in that tenancy, we assign admins, so we can create different admins that can access their tenancies as such. So if you've got permissions for that tenancy, you will be able to log into our backend with the password that we again just assign you as an admin. You'll get a login link to log in and set your password. Then you will access the bits of the platform that you're allowed to access as such. We do everything on role-based permissions. So when we set you up as an admin, you can have different roles. So it might be that this person can't look at patient notes, and therefore those roles are customized based on the permissions of that role as such. But the advantage of this is that you can go in and see, depending on your role, the back end of the platform, and actually if you have got permission to view the notes, you can. So when you log into the tenancy, you've got these tabs up here. So you've got the registered patients, and then you'll be able to filter things. So you can search by obviously NHF numbers, by name, also by statuses. So we have different statuses. Is a patient active? i.e. are they having appointments? They've got different discharge statuses. So, have they completed treatment, or have they dropped out? Have they only just registered before starting? So we have different options of the different statuses that, you can filter by and see that. And patients get access to their portal for life after that as well. So this is obviously a demo backend. I think we just find a patient on here. When you've found the sort of relevant patient that's come through, you can do a quick scan to see their scores and recovery. And let's go and click on a patient. So this is sort of where the electronic record system bit comes in. A patient that's seeing a particular clinician will be an episode of care. If they get discharged and come back, then it'll start a new episode of care with a new clinician. And then you can be able to see their sort of registration information, GP information, etc. You'll be able to view under the appointments, their upcoming and past appointments on here. And then the health history is that particular patient's clinical record. So again, you can see the summary information up here. And then you can click the sort of down arrow based on an appointment. Now, obviously, this isn't a very thorough clinical note because it's a demo, but our clinical notes are quite thorough. Obviously, there's an initial assessment note and then a follow-up note template that we utilize with risk management, etc. on there. But you can go and view that. You can also communicate with us as well through here if you want to. So you can upload documents, you can add different clinical notes, and then we'll add in discharge reports, etc. And you can also do a data download of all of this as well from the clinical record. You can view and assign questionnaires as well for patients. Now, what we do is patients will be automatically triggered to undertake their PHQ-9 GAD, I think the IMT. We do PHQ and GAD on every session. We also, if they have a particular issue, we have all the different questionnaires built in. So for instance, trauma questionnaires, etc. So they will be filling in those specific questionnaires based on their presentation to then accurately and reliably measure all the outcome data and recovery rates, etc. We have the ability to look at recovery charts as well, so you can see in the chart data. This person hasn't got data in here, but you'll be able to quickly view the chart of that recovery data. There's the messaging center, and again, this is customized completely as to how the patients we can set don't message you back as such, but we can message patients securely, etc. So there is a way of securely contacting patients through here that then gets the messaging on the back end. And then you've got the resource library function where patients can get assigned the resources based on the library, again searched by category and name here. And then those resources get assigned, but then you can also check, has that patient actually accessed that resource or not, based on the assigned count and the actions and the link access count. And then we can measure to see, right, well, have they accessed that resource and has it worked or not from that perspective. So you can access that to see, to look in real time. Having said that, I think, because you're using iAptus, when the clinician fills in the notes, it will then send those back to iAptus and populate into iAptus. So you don't necessarily have to log into the platform, but if you want to look at more detail, you can. The other thing that we have is digital therapy homework. We built this with a Innovate UK grant. I'm just going to get it up for you, because just while I do that, is there any questions on the back end? Now, obviously, there's a lot to it as the whole system, but I'm just showing you the sort of tendencies and the customizable setups. And likewise, with our resource library builder, we can add in specific resources as well, and that might be relevant to you. I think what we are doing across Cumbria, which is quite exciting, is using that resource library feature function as a social prescribing type tool where the whole population groups can access just the resource library bit. Because you can do it by tenancy, you can localize those resources and then also personalize them through the dashboard for what resources are relevant to what individual. And then, as I say, measure the outcomes of those resources. So have they accessed them, and have we actually got that person back to work or whatever? So that way, rather than it just being a generic resource library, I think to me that's quite an interesting way of doing social prescribing in the future. Because automating it online. Yes. So as I just did, any questions so far?
Julian,
sorry. Sorry, it's all right. Sorry, yeah.
For the Wellbeing Hub, we're using iAptus to communicate, and obviously with the back end stuff you've just shown us how we can access the notes, but also, am I right in thinking that the notes do populate into our iAptus anyway?
Yes, so they go back into your iAptus. So if you weren't using iAptus, you would add the patient via the backend on our system, but you are using iAptus. But if you wanted to go into more detail anyway, or there's something missing, you still we will give you access to the backend based on your roles from our system. But with the integration, the notes go back into your iAptus.
And does that happen live, Julian? Or
I think it's updated every 15 minutes. Is the API.
All right, brilliant. That's great. Okay, thank you.
I was just going to quickly show you our digital homework products as well. They kind of go alongside the portal. So if a person is eligible for digital homework based on how what the clinician decides, obviously the resource library acts as a bit of that homework, but we built out interactive tools as well. So there's a separate patient app. Every patient gets a safety plan with the local crisis number on here as well. So making sure that they've written that in. There's a mood and movement tracker. So this is essentially a way of goal setting with mood and movement tracker. So right, okay, let's try and make sure that we schedule activities for that individual, again, personalized to them to try and make them feel better or whatever. If they're so depressed they can't get out of bed, it's getting out of bed, then going for a walk or whatever. The patient will then rate their mood before, during and after the activity around pleasure, closeness to others and achievements. They'll be able to record that activity and then they'll be able to reflect on it. And then the therapist can see what's happened in that and then go through that with the patient. It's a sort of more interactive way of them doing their homework between sessions. So that's the mood and movement tracker. You've then got a thought testing module, which is around behavioral experiments. So the clinician will be able to set up experiments with the patient. So, different belief patterns. So belief A might be, if I talk in a crowded room, people think I'm stupid. Okay, well, how strong is that belief? Belief B is, no, they don't think you're stupid. Okay, so we're going to agree an experiment to test this. You're going to go and speak up in this crowded room. Patient will then go through and predict how they're going to feel. safety behaviors that they'll drop. So, okay, I'm not going to run away. Normally I would run away, but what's my safety net? So, okay, if this happens, I'm really worried about this. This is how I get out. So they've really framed it in their mind. And then they carry out the experiments, and then it's all about debriefing, creating the notes, etc. on that. So that way they can see how they're progressing, look at past experiments, reflect on them, etc. And the clinician can see that as well in the back end. There's then a worry tool to help with anxiety. So it takes you through the sort of worry tree. A patient will have a post-it note function where if they've got a particular worry, they can open the post-it note, put that worry in there, lock it away in that box, and then go through this worry situation. So, okay, I've got a worry. What is the worry? And then it will take you through the worry tree. Is it hypothetical? Is it real, etc. Takes you through that. So again, this is a way of helping people deal with certain anxieties. So there's the worry tool, and then there's also a mind tool which goes through understanding thoughts and belief patterns. So you'll go through this and go, okay, why do I feel upset? What emotions am I feeling? Am I thinking, okay, well, what's my main emotion? Describe a situation where you felt upset. The who, what, when, where, how did you feel? So you write an emotion. Okay, how strongly is that emotion? And it takes you through understanding why you had that thought in that particular scenario. And then can take you through sort of understanding unhelpful thinking patterns, fact versus opinion, thoughts against. And again, people can fill out as much or as little as they like on here, but we found that it helps to just improve the sort of therapy that we can deliver in that sense. So from a clinician standpoint, I think, you're not using the system yourselves, but obviously with our clinicians, it's nice because we can collect patient outcome measures with our form builder. So we can build out various forms with registration forms, etc. And what happens is that the notes auto-populate, so it's much easier for a clinician to write their notes, and we can build out those using a form builder to build out anything from that perspective. And that allows us to collect the data from the patient, which then auto-populates across, which makes life easier. And then likewise, our letters auto-populate from that perspective as well. There's a lot to that back-end platform, but I was only going to show you the bits obviously relevant. So I don't know, anything else to mention? Are there any questions?
I had some questions about how we refer over through IAPTIS, but I did send an email yesterday to Kathy and Amy. If you guys get a chance, please, would you just let me know today on that information?
Amy and Kathy are here.
Sorry, hi. Oh, let me put my camera on. Hi, Zoe. Can you see me?
Hi. Yeah.
Yeah, I was just waiting for confirmation from Paul, but basically the way that it works, once you're set up, within the care pathway section inside the patient in IAPTIS, there's literally a button that says refer to provider, and Dr. Julian, once we're linked, will be set up as a provider. You click Dr. Julian and everything, the referral comes over to us. Now, the initial assessment information, if there is any, will only come over to us if it's recorded inside the assessment tab. And I'm not sure whether you use that assessment tab or not.
We don't at the moment, but I think that's some information that we were just wanting to check. You don't get everything. You only get what we populate within that. Is that right?
Yes. So in the assessment tab, if you've got anything in there, that will come over to Dr. Julian automatically.
That's where we would put a brief summary of
yes.
Why we're sending the person within the assessment tab and send that. And then my other part of that was about what information in terms of the MDS stuff you get. So for the personal details. I've done a little list in that email, but if you would clarify that, that'd be brilliant. It's just for IG reasons. We're just needing to check that out. That'd be really helpful.
No problem. I'll just get complete certainty before I'm 99.9% sure, but I want to get clarity from Paul before I send that back.
Thanks,
I'll
Amy. That's really
today,
helpful.
Zoe, and get back
Brilliant.
to you.
Thank you.
No worries.
I think thanks for just putting the agenda back in. So, I mean, just from a summary perspective, I think the whole idea would be if you have a patient that wants to have a clinician immediately, then you refer into us, and we, as I say, we get them the right help that they need when they want it, and with the right tools and resources around that, from the self-care and the resource library perspective. And we do find our recovery rates are really quite good. I think last, was it 57%, and these are the NHS difficult patients that we're getting. So yes, Christine.
Hi, yes, thank you. No, that was brilliant. Thank you for going through all of that. I was just wondering, going forward now then, do you ever provide, you mentioned then your next steps on board and meetings, but obviously which Zoe, Richard and myself are having with yourselves. But for the clinicians, do you do any review sessions, like in a couple of months, how they feel the platform is working for them? Do we need to set up another session similar to this, or?
Absolutely, and we're always open to feedback. Absolutely, and yeah, it'd be great to have a review session just to get feedback. So you can always contact us to say what if anything's not working. We have that customer service team. We have tech support teams as well. But yeah, great to have a sort of round table, a discussion. Natalie,
yeah.
Just to check, how many sessions do you offer people?
So depending on, Kathy, you go ahead.
Yeah, so what we've agreed is, Natalie, that what we would do, because these are step 3 patients that are coming over, what will happen is that there will be 8 sessions assigned. And then if there's a requirement for further sessions, what we will do in-house is agree up to 12 sessions. So I should say that we do have a supervisory team and a clinical leadership team. And any extension requests are approved in-house. And then if it's the case, and this happens occasionally, it does happen, but it isn't protocol, that sometimes patients will require an additional 2 to 4 sessions. What we will do in that situation is our duty team will contact your clinical team, and they will provide a very detailed rationale as to why that would be. And then you would decide with us whether that is appropriate. And then if you agree, obviously that we will inform the therapist and add those sessions onto account for the patient. So what we're keen on doing as well, and this is another point, is that we do really push therapists to be putting in those extension requests as early as possible, because what we don't want is a disruption in patient care. So if they could put those requests in as quickly as possible, obviously we can then do the communication channels with yourself and we can get an answer quickly. And then the patient just carries on with the therapist until completion. It's a relatively easy and simple process.
That's great, thank you.
No problem.
I just wondered if we needed to share the diagram. Did we?
I was just about to say that.
All right.
I was just about to say, as in I just realised I hadn't shared that. So hang on. I think, have you been emailed it as well? I can go through it.
Yes. Yeah.
Sorry, I just. Right, I had it up. I don't know what's happened to it. Here we go. All right, let me just get it up. Okay, just share my screen. So kind of showed you how it works from the platform perspective, but let's just get this.
I think we're going to have to maximize that one, definitely.
Yeah, it's a little bit, okay. So if it's quite, hang on. Is it easier like that to see it like that?
Yes, that's better. Yeah, thank you.
Okay, so I think the agreed flow has happened. So if they're assessed by yourselves as suitable step 3 through us, you click on your IAPTIS refer to Dr. Julian. Then so on that time, an email is sent to the patient advising them of that and how to create their profile, which is a case of setting their password. They then can log into, which I showed you there, the patient-facing side of the portal. We give them 7 days in which to do that with multiple reminder emails if they haven't done it. If they don't complete it within that time, our customer service team will contact them via emails, and also we also try and attempt to phone them as well. A patient will then go and obviously hopefully book the appointment. Again, if they don't book the appointment within 14 days, so even if they've registered as such, our customer service team also contacts them and we send out those email reminders. If they once they've booked, the email goes out to the patient and the clinician to confirm the appointment. The clinician then needs to confirm the appointment, having looked at the patient to make sure that they're suitable for that clinician. The patient will then get sent the relevant questionnaires. They have to fill them in within the 48 hours of that appointment. And there's in-app reminders and emails to make sure that they complete it. If they haven't completed the questionnaires beforehand, then the therapist can complete them during the session with them. They have their appointment, and obviously they just have to be logged into the platform at the time, and we do the video, our secure internal video system. Then once that's completed, a clinician will then book that patient into a follow-up slot. So the patient or us will book the first session, but then the clinician will book them in for following sessions based on what they agree. The therapist must complete, obviously, the clinical notes. Those clinical notes, as I said, go back to IAPTUS. When that patient is suitable for discharge or completes that episode of care, then we create a discharge report, as I was showing you there from our discharge reports from our form builder. And then you will get a copy of that discharge report and a notification that discharge report is done. And we also send that discharge report to their GP as well. And the patient can access that discharge report, as I was showing you, from the patient dashboard. And then that's the end of their journey.
Julian, how soon after you've discharged them and will the discharge report be done and received by us?
Well, the discharge report gets done on discharge. So that's done when they are discharged. So immediately, yes. Because they can't discharge the patient from our system without completing the discharge report.
Okay, brilliant. And that then comes straight over to us. So there's not really a delay there.
Yeah, so you get notified of that. And I think, yeah. So Amy, do you want to talk through that process because of the IAPTUS integration?
Yeah, absolutely.
With the discharge report?
Yeah, absolutely. So the therapist will complete the discharge report on the Dr. Julian platform, Zoe, and that's all templated. You'll receive an alert to let you know that that discharge report is ready. It's not part of the API integration, so it doesn't get sent back to IAPTUS. So at this stage, there's two options. We've got a full customer success team in-house who can either send you a secure copy of the discharge report. That will be done via nhs.net email. So we can do it that way. Or some of our tenancies would prefer them not to be coming over email, which is understandable. And because they have access to the Dr. Julian platform, they can upload those discharge reports from the platform very easily, literally within the patient's profile. And there's an upload button, a download button, and then you can upload it to IAPTUS. The other option, of course, is that we upload it to your IAPTUS for you as well. We can do that if we have token access. So there's a few different options and different workarounds depending on your resource and your requirements. That's something we can fine tune before we launch.
Brilliant, thank you. And in terms of the notes then, Amy, when the notes are sent over, do they populate straight into IAPTUS, or is there something manually that we need to do? No,
there's nothing else manual, with the exception of any reports and letters. So if there's a GP letter or a discharge report, they won't be sent via IAPTUS. However, you'll be alerted immediately. So as soon as that clinician hits save and send, which is the completed version on our side, you'll be alerted via email. So you would pick a designated, either one person to receive those alerts, or a central inbox, or multiple people, and that's absolutely fine. You'll get an alert to say it's ready. At that point, you will either go in and download it, or we will be sending it across to you.
Brilliant, thank you.
Natalie?
Sorry, another question. Just want to check, is there any kind of particular exclusion criteria, people that you wouldn't be suitable for your service?
Okay, and that we only really have 4 exclusion criteria. Okay, and again, that this is dependent on the type of service that we're working with. However, the first exclusion criteria is active risk. So we haven't got the infrastructure at Dr. Julian to be managing urgent risk. However, that said, because we are all thoroughly trained in risk assessment and risk management and doing safety plans, we will ensure that that happens. And what we will then do is we will do the referral onward to the relevant crisis service, or whatever the case may be. The second one is when alcohol or substance misuse is the primary presenting issue. Again, if somebody is using substances, it doesn't necessarily exclude them. It's more about whether the use of substances is going to impact with the therapeutic engagement. And sometimes it's more relevant that that particular individual has intervention by drug and alcohol services first. The third exclusion criteria is when they're already engaged in therapy with a different provider, because that causes a bit of conflicts of interest, confusion, and it is possible to over therapy somebody. And the fourth criteria is if they needed specialist MDT intervention from a secondary care mental health service. So sometimes it might be in the patient's best interest. And again, it's not a one size fits all, because there are variables involved with that. However, if it's a case that we feel that there's round the clock care required, an MDT approach is required, particularly to keep that patient safe and to help them, we would do the referral onwards accordingly. That said, we do have patients in similar services such as yourselves who may be under the care as an outpatient and seeing psychiatry every 3 months, and it's usually just for a review of their medication, and that's probably it. And in those circumstances that we would continue to see them. So yeah, so 4 criteria, however, that there is flexibility within that criteria. So for example, if I just go back to the drug and alcohol, if somebody is drinking excessively, but let's say that they don't start drinking until 3 p.m. in the afternoon, that we would see them in the morning. So that there's ways around it. If we can find ways around it, then we will. But obviously that we'd have to be assessing the behaviour, etc., and seeing what the potential impact would be.
That's great. Thank you.
No problem.
Brilliant. Thanks, Kathy. Richard?
That was a really helpful question. Now, thanks for asking that.
Yes,
thanks for your answer, Kathy.
No problem.
I wondered, so everyone who we're going to send on to you will have come and met one of our expert clinicians and had an assessment to come on to you. I suppose what I'm wondering is that if when you're seeing a patient and they're deteriorating or something else comes up and things like that, have we got protocol set up where you're happy to come back to us in that sense? So it doesn't have to be at discharge, that you could reach out to us and say, therapy's okay, but they might need a little bit of additional support from your service while they're going through their therapy, or something else seems to be going wrong, or we've discovered something else. Have we got that? Do you think your therapist will be happy kind of reaching back to us if something unexpected comes up?
What happens in those circumstances is this. So we are very keen to work in a collaborative way with yourselves and keep the open communication there, and work with transparency. What happens in those situations is when we set up the tenancy, which we are going to achieve on the 10th, we will take your details of your clinical team that you want our clinical team to liaise with. And when we do the communications, these are on an ad hoc basis and are specifically in relation to patient care. So what happens is, if a therapist is working with a patient and they feel that either their presentation is deteriorating, or that the patient could do with some additional support, let us say that that's some additional support around occupational health, what the therapist will then do is that they will contact our central clinical team, who will then speak with your central clinical team. Sometimes it's a case of that we are aware of specifics that you have in your services that could support the patient. And sometimes it's a case of we are asking you the question, have you got a particular intervention in your service, or is there something in the locality that would be a particular use? And we would be working in collaboration that way. So to to answer your question in summary, we will keep the communication channels open. We support our therapists in-house with any clinical query that they have. And of course, in situations, as you've described, Richard, we will be contacting you and we will be asking if there's any additional support available. And obviously that additional support, it could be a variety of different things. So yeah, so the tenancy set up on the 10th of November, we will be taking the details of your clinical central inbox. That could be a person, it could be a central email address that many people could pick up. Obviously that choice is yours. If you tell us, and that we will put it on our duty SOP, and when we have to communicate with you, obviously that we will be contacting that email address, and of course, that we'll be giving you our telephone details as well. And if a telephone discussion is required, that we can do that as well. One of the other things is, and while this is fresh in my head, what we can do as a way to review, and this goes back to one of the previous questions, we can arrange what's called clinical interface meetings. And this is where we can discuss, if necessary, particular patients and come to care pathway decisions. And we can discuss anything around sort of DNA waivers, extension requests, or whatever the case may be. So if that's something that you want us to do as well, that we can offer that. So that sometimes some of our customers that they prefer sort of adding those on to the performance and contract meetings. However, if you want separate meetings and some of the clinical staff want to attend those, that we could offer that as well for you. So it depends in terms of what you want and what you require, and we will flex accordingly.
Yeah, so thanks, Kathy. I'm really pleased to use that word collaborative, because we'd like
yes.
to be there for people if we can help. So, you know,
absolutely.
We don't want to just send to you and forget and leave the problem with you. That's not our attitude.
No.
Yeah.
No.
Okay. Thank you.
No
Right.
problem.
So I'm just conscious of the time as well. Has anybody got any other final questions, or?
It's me again.
One more,
Sorry.
I knew you would.
I know, I can't help it. Just to clarify, in terms of when we're starting, we're still aiming for the 17th, is that right?
Yes, yeah, I was just going to cover that in the next step. So
Brilliant.
yeah. So yes, so as Zoe's mentioned, yeah, so we are aiming for going live on the 17th of November, and just a little gentle nudge again to the guys at Dr. Julian, just that all depends as long as we get the data sharing agreement. So I desperately need those. Obviously that will not take as long to do for this one, for the hubs, for the server side, because it's obviously just with, I'm assuming Richard or Zoe will be signing that off. So if we can get that through, and then we can get the contract signed, and then everything's going ahead for the 17th of November.
And have we got the code from Maiden yet, Zoe? Is that in
No,
hand?
so I'm meeting with them on Tuesday with Michael. We're going to meet with Maiden. I think we've got an agreement on the costings, which is progress, but we just need to have that meeting, and I think then they can set that up from there.
Lovely.
Yeah, likewise, I also just need the data sharing agreement back.
Okay, I'll chase
and
Paul for
the other
that
thing
today.
that's also pending in the background is obviously the DPIA, which is currently with our IG team. So as long as all of that goes ahead,
yes,
hopefully 17th will be the live date.
Perfect. Well, we'll have, like as Kathy said, the tenancy is being started to be set up on the 10th, which is plenty of time our side to make sure everything's there. The last piece of the puzzle will be well, once everything else is signed off, obviously, will be this code from Maiden.
Yeah,
because
that's fine. As soon as I've got that, I'll let you know.
Yeah, let me know. Because once we've got that, I can make sure the integration's working, send you over some test clinical contacts. You can make sure you're happy with the data that you receive back, and it's as you would expect it to be. And we get sign off of that as well. That doesn't take long. We can do that in an afternoon. So
perfect.
I'll chase Paul for the data sharing agreement.
Thank you. Yeah, if you wouldn't mind. Yeah.
No problem. I'll chase that today. Simon's in as well, so I can speak to Simon. Let's get that over to you as soon as possible. I have sent I've reviewed the contract. I'm happy with it. I've sent it over to Julian. Julian, I sent that to him yesterday.
I'm happy. Yeah, I'm happy with it, so we can sign it. Yeah.
Okay, so
Brilliant.
I'll make sure Julian gets that signed today, and I'll get that back to you, Christine.
Well, we'll send you out electronic version for electronic signature.
Oh, okay,
That's
perfectly
good.
fine
Yeah.
then.
Good.
Perfectly fine. I'll just drop you an email then saying we're happy with it, and await your electronic copy then.
Yeah, brilliant. Richard, did you want to come in there as well?
Yeah, it's just to I know you've discussed this, but it was just to raise that that issue of Maiden charging £5 per referral, and it took us about a bit by surprise, and
Crazy.
but
Yeah, that is crazy.
it is crazy, isn't it? And I suppose my concern is that if this works really well and we want to increase referrals to you after this pilot, that's going to start getting quite crippling.
You can do it a different way. You can refer directly in.
Well, it may be that we'll need to look at something creative like that.
Well, you just it's really simple. You just refer in as an admin, and then
I guess the only thing with that is you're not going to get the notes back, and then you're looking at admin resource.
The links are brilliant, aren't they?
Yeah.
It's not as efficient. That surprised me though, Richard. I've never heard.
I mean, you can do a download. You can do a download of the notes and then put them back, and then have you know.
I also wonder whether you need to know about it, because if they're doing it with us, are they going to start doing it with the other providers too? And it's going to with money being so tight in the NHS, it's going to start being problematic. Even it doesn't sound a lot, £5 per referral, but it will build up.
It will definitely build up. Yeah, it's good to have that information. Thank you for sharing. But yeah, we can certainly look at. I mean, if they do go up, we can look at downloading notes, so we can export them in CSV files.
Them and then upload them.
And then you can upload them, so we can do it in a bulk job lot that you could upload. That could work. We could look at other things, but then it's going to be a manual referral. It's just time for you guys, I guess.
Yeah, no, and I mean, it's good at the moment that we've got it for this next year. I was just anticipating, especially if referral numbers go up and this becomes really successful.
Maybe we can speak to Maiden about that charge, because it seems excessive.
That's what Dave was saying, Dave, weren't you, about, if it does scale up, we need to really negotiate that.
Yeah, I think that's my concern, because it took me a bit by surprise as well. I think it's just the level per referral. I understand kind of setup costs and all that, and I think there's no getting away from that. But then once that's all done, there's actually no work involved. So for such a high per referral charge, really surprised me. With other companies, you know, if they'd said, well, it's 10p per referral or 20p referral, I wouldn't have batted an eyelid. But
can we set a meeting up with Maiden? And I can be on it.
I think Paul would be best for that. Julian's got a really good relationship with Maiden, but £5 does sound excessive. Can I just ask, was that based on? Was it based on number of referrals? So the more referrals you sent, the less that the charge was, or was it?
No, it wasn't. It's a set prism cost. So I sent over the manual that they've sent, and at the back it says about if you add prism, these are the costings. It was something like 1,695 plus VAT for the setup, and then something like £4.45 per referral plus VAT. Yeah,
I think that'd be really helpful though, if we can involve Paul and that discussion.
Shall I let you guys know after I've met with Maiden on Tuesday where how the land lies, and then we go from there in terms of.
I think as well, Zoe. All I would say is that if we've got the costs agreed for the cohort that we've already agreed, and we're at the point of signing contracts, don't let this be a limiting factor. However,
I think
as we move forward. I think we need to understand the basis for those costs, because when you first sent them over to me, I did take a sharp intake of breath. That's a lot of money per referral, and I'm not used to seeing levels like that per referral from other providers. So I would want to, but I'm not contracting with them, so I'm in a difficult spot, which is why I was saying to you, if you can escalate that internally, then I think it's worth an open conversation with Maidens to say, look, what is driving this, and actually that does become very restrictive once we start to scale the service.
Yeah.
And I think from your point of view, Julian, from a Dr. Julian point of view, as Richard just said, if they're going to apply this across all of their connectivities to the other providers you're working with, that potentially is a significant issue.
I did flag it as well with the ICB, and I did say it might be something we might need to escalate back to yourselves if the referrals, like you said, Richard, are going to go through the roof, and they were quite
surely the
open to
ICB
us bringing that back,
Maiden. and be like, guys, what are you doing? This is ridiculous. Yeah.
Okay, so we just need to keep an eye on that.
I think
Brilliant.
we
Well,
probably need
yes.
to find out who is the most senior person within CA2W who oversees the IAPTUS contract.
I'm not sure there is anyone, Dave, because we use Rio all the time. So IAPTUS is just hardly anyone uses it.
But somebody must have signed a contract with them.
The original contract, yeah.
At some point. We maybe just
I'd
need
ask
to work
Maiden
with
for it, Zoe. Why don't you ask Maiden? And if you can't get it within the organisation,
let's pick it up after today. We'll have some sensible
digging.
conversations with them.
Yeah.
Yeah.
Okay.
Just switch to our system, guys. But don't tell them.
So apart from that one issue, we're virtually nearly there. We're nearly over the line. So we're going for the 17th, fingers crossed, all being well, which, just to flag, is a week on Monday. And we've obviously got the next webinar on the resource library side for all the WorkWell teams out there across the Northeast as well. So just say thank you very much to everybody. Yes. And obviously it's all been short notice and done at the last minute. And so for all your help and support, marvellous to help get this mobilised. So we're nearly there. We'll also send you a copy of this link to the recording and an information pack out as well. But thank you very much. Thank you. And thanks for your time.